Okay, so welcome everybody. This is Diane. Want to go back through just over our basic slides. The first is the key driver diagram for the Maternal Hypertension Initiative. One thing I want to, some of the changes that we're going to talk about today begin with this slide. So one of the updates that we've made in this section with the recognition, if you kind of follow over under the education, that fourth kind of bullet in that orange box where it has the education, we've added in the measure for implicit bias education that's going to be that has been added. Dr. Kotke, is there anything else you wanted to say about the driver diagram?
No, I think that, over the past handful of months, and also welcome to the new hospitals, we're excited to have you. But we've been talking for a long time now about the inequities that we have in our state with regards to maternal morbidity and mortality, and have been working with a lot of folks, some on this call, some not on this call, about how we can integrate health equity work into this work. Working in quality improvement is actually a step towards improving equitable delivery of services, but we wanted to be really intentional about additional things that hospitals can do. So one of them is to, for us to track concretely that folks on your labor and delivery units have received implicit bias training. That is one thing. The other thing that we'll talk about on today's talk later is that we'll be collecting data that that measures, like when we look at the time to treatment. Our plan is to collect data on time to treatment and be able to look at if there are any differences at the hospital level of time to treatment based on race and ethnicity. And I think that's looking at, for having each hospital be able to look at their data and understand if there are things that structurally or systemically we are doing that are contributing to these disparities, I think is a really important tool for us all to have. And then the final component for this particular driver diagram is also when hospitals are doing debriefs about a particular severe range hypertension experience or outcome, that when the team comes together, that we kind of set the stage. That part of that debriefing process is to ask the question: to what extent could our biases have contributed to this event and this outcome? I mean, it is possible that they did not, but to have a concrete way that that conversation can happen and that people can feel supported in having those types of conversations were a couple of the things that that the team, and I've used that word very largely, have been talking about we could add to what we've already put together for this driver diagram. Does anybody have any questions about that or comments? Good. One of the things that we will also be doing, Caprice Welsh has done a great job of helping put together our team that has given feedback on health equity. And so we will share resources about ways to get implicit bias training, and are also talking about if we could offer that kind of as a group as well. So that'll be coming up over these next couple of months too. Diane, I don't have anything else.
Surreal, will you? Okay, thank you. Okay, and so along with those changes, so there will be some adjustments to the hypertension structure and process, or at least to the structure and process measures. So I won't read these out in detail. We're going to review every time. But the 5 structure measures for hypertension haven't changed. Get to the next slide, Terrell, please. Thank you. But for process, do you want to go? I'm sorry, go back, Terrell. I apologize, everybody. We're doing hemorrhage and hypertension today, and I'm thinking that you've already seen this, but this is still pretty new. What the report and the reporting process and the measures that we're going to be using. So I will go through that in a little bit more detail. So for S1, it's patient, family, and staff support, and the measure on the report form will be just to look at where you are with your hospital having specific resources and protocols to support patients and family and staff. The structure measure for debriefs. Do you have a system in place that's been established to perform debriefs? The multidisciplinary case reviews, having that process in place to review on all cases of severe maternal morbidity. Unit policy and procedures, have those been developed? And I think, just like we did with hemorrhage, with unit policy and procedure, for those of you that worked on that measure or that initiative, for us to be able to share with one another, anybody doesn't have this in place or in the process of developing, that's certainly something that we would like to be a resource for. Lauren, working with the hospitals, can certainly help, facilitate sharing of materials, and with them where the hospitals are with integrating this into your electronic system. Okay, go to the next one, Terrell, please. Okay. So for the process measures, these are, we're at the end of our first cycle of reporting for the hypertension bundle. So for the period of July 1st through October the 31st, for both the structure measures that I just went through and the process measures that are here now, you'll report on those by the end of October to Terrell here in the office. And so the exception to that on this set of measures is P4 and P5. So you'll report on the 5 that we just went through, the S1 through S5, and you'll report on P1, 2, 3, and P6 at the end of October, and again at the end of January. So for those first 2 quarters, those will be the 4 process measures that we report on, because we're still in the process of everybody working on developing how your hospital is going to report on P4 and P5. So for P1, the unit drills, we'll report on that at the end of October for that first quarter. Same with provider education for preeclampsia, and the nursing education for that. And then down on P6, the implicit bias training. We'll begin to report for this on the number of providers, nurses, and OB staff who received training on implicit bias. Are there any questions so far? Okay. Terrell, will you go to the next slide, please? Thank you. And just to review the goals of the hypertension initiative, is that the number of women with severe maternal morbidities, there'll be a 20% reduction among women with new onset severe range hypertension, 20% reduction by December of 2021. And we did look at, modeling this after a state, Illinois, that has been successful in achieving it. It's kind of a lofty goal, but we want to keep that in place. The appropriate medical management in under 60 minutes, 100% for that. Debriefs on all new severe range hypertension cases, and discharge and follow-up within 7 to 10 days for all women with severe range hypertension. Okay, next slide. Okay, Lauren?
Yes, sorry, I was on mute. Okay, so thanks everyone for joining. We are going to talk today about accurate blood pressure measurements. I know that might seem a little bit rudimentary, but we all know that there are some practices that either we were taught or we picked up along the way that don't constitute the best practice. So we thought it's important, and we've learned from just speaking to other states that have implemented hypertension initiatives that it's really important to ensure that staff are all on the same page with identifying severe range blood pressures, and that may actually have to start with learning how to, making sure that we're all taking the blood pressure in the same way. Next slide, please. So as we know, it's a basic clinical assessment. We all get taught it in nursing school. But however, when it's not accurately performed, it's going to, of course, give the wrong reading, and it's going to lead to either delays in diagnosis and management, or mismanagement, or delays in treatment. Next slide. So when we think about recognition, particularly in light of the bundle, we are looking at acute onset. So severe hypertension that is accurately measured using standard techniques and is persistent for 15 minutes or more, and that is what is considered a hypertensive emergency. Next slide. So we all know that in the hospital environment, and I'm assuming that most of us that are on the phone or on the call or on this webinar are mostly based in the hospital environment, but also some of us may be based in clinical environments. And there's going to be a variety of different types of blood pressure recording machines that are used. So this just provides a basic overview. This was adapted from a journal back in 2008, but nothing really changes with regards to how we take blood pressure. It's really important that we have the correct equipment, right-sized cuffs, that we don't allow the patient to, we know what it's like when the patient comes in, or she's been rushed, or she's just woken up from sleep. That's not the most appropriate time to take a blood pressure, or if she's had any caffeine or nicotine. That again is going to give a false reading. So it's really important that as we look at these recommendations, that this is what's shared with the staff, all of the staff that are involved with taking blood pressure. So that may not just be the nurses, it may also be your nursing assistants or your techs. So any education, any re-education that you do really should be consistent across the board. We'd like to also include our medical staff as well, if they ever take blood pressure. So something like this slide that's posted may be a good thing to put out on the unit, or put for education for staff to look at, to ensure that they are making sure they take the blood pressure accurately. We've all seen, some of us may also be guilty of putting the patient in a position or taking the blood pressure on the lower arm to get a lower reading, but of course that's not best practice, and it's not also going to help with accurate management, and may also miss something that could result in a severe range blood pressure or hypertensive crisis. Next slide, please. So again, we've got a vast array of nursing staff that are on the call. Those of you that I'm familiar with, some of you have been nurses for a long time, so you may be familiar with the older sphygmomanometer, the mercury one that we see in the picture there, and that is the gold standard. And then, of course, as time has modernized, we've seen more newer ones, and most of us perhaps have automated ones that we see in our clinical areas. To be honest, when you look at the literature and when you look at recommendations, say, from the American Heart Association, it is important to understand what is, that there are variants between the type of blood pressure recording monitors that are used, and you can have a variance of a few millimeters of mercury to more than 10, and of course that can affect how the patient's condition is managed. Next slide. So these are perhaps two of the ones that we're most familiar with. It really is important to make sure that your machines, whether you're using a Dynamap, such as the blue one in the right-hand corner, or it's part of the fetal monitor, that regardless of what type, what model or make, that it's regularly checked and calibrated by your biomedical department. Make sure that there is no abnormality in the readings and that it's correctly calibrating. Next slide. So when we talk about clinical variance that sometimes occurs with the different types of machines that are used, the International Standards Organization, that's what's used by manufacturers to test against the mercury sphygmomanometers, which are considered the gold standard. So you're going to probably get a variance of about 5 millimeters of mercury with the different types. So that's plus or minus what you get in the reading, and your and the standard deviation of no more than 8 millimeters of mercury. So that's why it's really important that even if you do have automated devices, it's really important to also ensure that you have a manual sphygmomanometer so that you can always do a backup blood pressure just to confirm if you've got a huge variance between the two, whether it's automated or whether it's manual. Next slide. The other thing that's really important is also to ensure that you have appropriately sized blood pressure cuffs. Some facilities may have automated blood pressure machines. It's still really important to make sure that you have different size cuffs, because as you know, we're not all the same size. And if you have the wrong size cuff, again, it's going to cause the wrong reading, and again, can lead to either missing something that would be managed, or masking what could be really a severe range blood pressure or an increased blood pressure. So it's important to know what manufacturers you have and what size cuffs they have, and in particular that all of those are available and accessible in the units, whether it be your triage, labor and delivery, postpartum mother-baby, or antepartum unit. Next slide. And again, we're going back to rudimentary, but this is something that is really important to share with the staff, particularly when we are starting this initiative, and also for monitoring compliance. We want to make sure that staff are following best practice and are using the right size cuffs. It's easy sometimes if you've got them already in your drawers or in storage, or they've been ordered, and that's the only thing that you've got available, that you may decide to use that, staff may decide to use that. But it's really important, as you can see from the graphic that's there, depending on the arm circumference will really dictate the size of cuff that's needed. And again, this is another slide, and this whole slide deck can be used to help with education with staff and helping them to make sure that they do take blood pressure correctly, but also once you've actually done that education with them, that they can continue to go back to this, and then you can hold them accountable for ensuring that they are following best practice. Next slide. This slide goes over the consequences of using the wrong size cuff. As you can see, it can either overestimate or underestimate if you've got the wrong size cuff. And when you see the first point there, that if the cuff is too small, it can increase the systolic as much as 15 millimeters of mercury. And again, that's going to wrongly diagnose the patient as either having a hypertensive crisis or hypertension. So these are just some techniques that needs to be considered when blood pressure is being taken. Next slide, please. So let's just go into technique, patient preparation and positioning. We, as OB nurses, we can get into bad practices of how to take patients' blood pressures. I've heard and seen a range of different ways that blood pressure is taken. And you all have probably experienced this as well, that we seem to have a fear of recording a blood pressure that's elevated. There are so many ways to cut corners. So it might be laying the patient down flat. I've even heard of lowering the patient's head or taking the blood pressure on her lower arm to ensure that we get a lower blood pressure. Now, these are practices that really we need to discourage, and we really need to make sure that our staff are not doing them, particularly as we are starting to monitor how our blood pressures, severe range blood pressures are treated and whether it's done in a timely manner. But if it's not done correctly in the first place, then we may miss a lot of things. Patients should be sitting upright or in a semi-reclined position, arms at heart level, legs uncrossed, and feet flat. Her back should be supported and be sitting for 5 minutes before blood pressure is taken. And in particular, when patients are admitted to the unit, whether that be triage or in labor and delivery, encourage staff not to get into the habit of ignoring an elevated blood pressure because we think she might be in pain. It's always important that if you do get a blood pressure that's recorded during a contraction or when the patient is in pain, that it's repeated when she's not. Give her a few minutes to sit quietly if she's just come into the unit, and make sure that you ask the question whether she's had any nicotine or caffeine in the last 30 minutes. So don't forget things like not just coffee, but any sodas, any Coke products, or anything like that. Sometimes we are guilty of asking them questions while we're taking their blood pressure as well. And again, we may not realize it, but that can also give errors in recording of the blood pressure. Next slide, please. And this is why it's so important to make sure that we follow the advice that was given on the previous slide. If the back is supported, back is unsupported, there's data that shows that that could actually increase the diastolic by 6 millimeters of mercury. If the legs are crossed, that can be up to 8 millimeters of mercury in the systolic blood pressure. If the arm is unsupported and allowed to hang down, the blood pressure can be elevated by up to 10 to 12 millimeters of mercury. So again, that could push the patient into either a hypertension diagnosis or a severe range diagnosis. So again, it's really important that this is discussed with staff. If the patient is talking, again, depending on what's going on with her, you can see how much that can change and increase the blood pressure. So it's really, really important that this is discussed with staff and that these practices are followed because, again, it can lead to inaccuracy. And just remember that we know that pain and anxiety can also increase blood pressure, but again, it's not an excuse to not retake or to not follow through if the patient is in pain. Again, once she's been given some analgesics, if possible, to recheck the blood pressure and to see whether there is any difference in what was taken. Next slide, please. So again, this goes back to what we were taught in nursing school, and for some of us it may be such a long time ago and we may have developed some of those bad practices. It's not a bad thing to actually go through this and remind ourselves of what we should be following, as well as making sure that we teach our staff, junior staff, if we've got residents on the unit, if we've got nursing students, that we make sure that when we are assessing them and checking them off to make sure that they're competent, that we make sure that they follow this. This may not actually be a bad thing to do. I know this was done in one of the facilities that I worked in some years ago, where we had to go back to basics and do a competency to make sure that all nurses were following best practice and taking the blood pressure correctly. So that might be something that you might want to consider in your unit, particularly if it's you do it annually, again, just to make sure that all staff are following the same practice. Next slide. The American Heart Association recommends that when taking blood pressure, to retake in the other arm, so to take on both sides. Again, this is something that we're not necessarily doing in our facilities, but of course, if the blood pressure is more than 140 systolic or 90, equal to or more than 140 systolic or equal to or more than 90 diastolic, to repeat in 15 minutes. One of the things that I've come across either in practice or just seeing it or talking to some of you all, that sometimes particularly when we're looking at severe range blood pressure and when we're treating, that sometimes staff can forget that we're not just looking at the equal to 160 or equal to 110 as a means for treatment. It's also important to recognize that if the patient has a reading of equal to or above 140 systolic or 90 diastolic or more, that is hypertension. So we do need to repeat to ensure that that is a correct reading and to monitor that, and of course notify the provider in case the workup needs to be done. Be careful when using automated blood pressure cuffs because they can overestimate. So again, if you're getting into that range of hypertension, that's where it's important to be able to either repeat or use a manual blood pressure spig so that we can ensure that there's not a huge variance between the automated cuff and the manual cuff. And again, please, we, as well as reiterating it here, we've got to ensure that our staff do this, that we don't reposition the patient to either side to obtain a lower blood pressure. We're not helping anybody. In fact, we could be hurting the patient by not recognizing if she has hypertension and that we're not appropriately treating or managing. Next slide. Many of us work in facilities where we have electronic medical records where we can document the blood pressure. It's important to document the patient's position and the location where it was taken, whether it was right or left, and the cuff size if there's a means for that. If there's not a means for that, it's important that that cuff is placed in the same place so that it can be used for the same patient consistently. The important thing is really to get consistency. So whether it's documented in the medical records or on her blood pressure chart, or I've seen some facilities where they actually write it on the cuff with a Sharpie so that the next person coming along to take the blood pressure on that person knows where it was taken previously. So again, to provide some consistency. Next slide, please. And just to follow the same theme, it's really important to be consistent, same arm, same position, and same cuff size. Just as we mentioned earlier on, it's important that if the wrong cuff size has been used and it's been recognized and it's been changed out, that is consistently used to ensure that the blood pressure is taken correctly. It's also important here, again, this is a recommendation by the AHA, that when you are using automated blood pressure monitors, and I know this is convenient for us, particularly when we have a patient in labor and we're cycling the blood pressure at regular intervals, that we put it on auto cycle. It's important to go back and check because we know that sometimes the patient will take it off because it's uncomfortable, or she needs to change position, or she gets up to go to the restroom, and then she puts it back on, or somebody else puts it back on, a family member or a spouse, and it may not be put on correctly, or if the patient applies it herself. So it's important that if you do use auto cycle, and you have to, that either you're present to ensure that the cuff is correctly placed, or that if it's taken off, that you reapply it and don't just leave it to cycle and expect that you're going to get accurate recordings. Next slide, please. And this is why arm position matters. Upper arm is going to lower the blood pressure. I guess we already know that. And lower arm is going to have a higher blood pressure. So again, if you've got a patient who's, say, in labor, or she's more comfortable on one side or the other, it's still important that regardless of which arm that you use, that you have consistency, and that staff are taught not to switch to the upper arm to get a lower blood pressure reading because it's higher than the heart. it's important to be consistent. And again, if the patient is, lying on one side or the other, and you have to switch arms, that you document that you switched arms so that we can see whether there's any variance, or those staff that are following can see whether there's any variance in the blood pressure. Next slide. Again, we'll keep talking about why position is important. If the arm is above the heart, it's going to lower the blood pressure even more. And the picture on the right, we've seen that all too often, that the cycle in the auto cycle is recording or maybe inflating without it even being on the patient. So it's important, again, as mentioned previously, that if it's on auto cycle, that we make sure that we go and check, and staff checks regularly that it is actually recording and that it's appropriately placed. Next slide. Again, there are going to be factors that will have an impact on the blood pressure. We've talked about position, maternal position, we've talked about the cuff. We also know that sometimes when the patient is in pain or during contractions, having an epidural being placed, or when she's pushing, that's going to maybe change the normalcy of blood pressure readings. Again, if you have a huge variance, it's important to document that as to the reason why. But if you have a severe range, or if it's a hypertension, that it is, and that the new onset, that it is repeated, hopefully outside of those times when that is listed here, just to see if there's any change again. Next slide. So another thing that we have to think about is we're increasingly getting patients that have a high BMI, and so we've often got creative in our departments, perhaps because we don't have the correct size cuff. So what do we do when we've got patients who've got a BMI of 70 or more? Next slide, please. So this is a point of consideration, and again, like I said, our population is getting bigger. We see more obese women, so it's important that when considering taking blood pressure in obese women, that these are the things that we need to consider: the size of the arm, the shape of the arm, the length of the arm, cuff sizes and shapes. So the standard cuff that we may have on the unit may be inappropriate, and this is really important, and maybe something that many of us probably didn't have much education in when we were going through nursing school. But of course, as times have changed, we've seen that these are some of the challenges that we face, if not every day, certainly on a regular basis. Next slide, please. So we often see that sometimes we've got patients who have got a large arm circumference. So these are some things that we have to consider. When the arm circumference near the shoulder is more than the arm circumference near the elbow, you're going to get a poor fit of the cuff, and so you're going to have an inaccurate blood pressure. If the arm circumference is large and there's a short humeral length, again, we're going to have an inaccurate blood pressure recording. Most of the, particularly a lot of the disposable blood pressure cuffs that we have are more square as opposed to cylindrical, and that is probably not going to be the best bet for a patient with a large arm circumference. So you may have to use a thigh one, but if you go to the next slide, that might explain a little bit more. And again, in using a cuff on a patient that's obese, you can have, it can alter the blood pressure, overestimate by 30 millimeters of mercury, and that's huge in terms of how that's being managed. So it's really important that we consider, if we don't already have those on our unit, and depending on our patient population, and I'm sure it's across the board, that we may need to consider getting some new cuffs in to be able to adapt to those populations. Next slide. And these are just some articles that confirm what I've just mentioned. In obese people, the upper arm may have a pronounced troncoconical shape, and cylindrical cuffs may overestimate. Troncoconical cuffs should be used for blood pressure measurements in individuals with large arms. And in a couple of slides, I'll have some some graphics to show you what that means. Next slide. So again, some of the best practice recommendations from the American Heart Association is that it's important to measure the arm. And this is I mentioned this a little bit earlier on. For upper arm measurements greater than 50 centimeters, the AHA recommends using a cuff on the forearm and feeling for the appearance of the radial pulse at the wrist to estimate systolic blood pressure. But this is not as reliable. But if you don't have cuffs, thigh cuffs, then this may be the only thing that you have. Next slide. So that leaves the question, what can we do to improve blood pressure measurement accuracy? Next slide. So it's really important to make sure that there's proper training of staff. And again, as was mentioned earlier on, incorporate blood pressure measurement into a skills day or do an annual review or develop some kind of training module. There are quite a few very good videos that can show how to do this, and it might be helpful to show that to your staff. And I will make sure that this link is provided in the follow-up email so that you can use it as a tool. It's also important to also put poster boards around, making sure that staff are constantly reminded. We know that sometimes there is so much for staff to take in, and again, it's hard to change bad practices. And often what happens is if you've got bad practices that are already existing on your unit, and then you've got new staff coming or junior staff or students, nursing students or new nurses, they're going to get trained the same way. So it's really important to continue to reiterate over and over again and perhaps put up poster boards or there's a poster, steps to obtain accurate blood pressure on the units as a way to remind staff to be cognizant of what they should be considering when taking blood pressure. Next slide. And I do in particular like this slide because I think it does catch your attention, and this is from the American, it's in conjunction with the American Heart Association and the American Medical Association, but it really does provide some food for thought, and this is a great graphic to put up in your staff rooms, in your patient rooms, or in the education rooms to remind staff what to consider when taking blood pressure, and just to see just how not maintaining best practice can lead to increases and incorrect management or delay in management. Next slide. Some facilities have a blood pressure kit, and this may be what's in your patient rooms. It may be in drawers on the patient stand, on the bedside stand, or where they keep the equipment. But it's something to consider. Different sizes of cuffs, a sphygmomanometer if there's one available that can be in the room, or one that can be accessible if necessary. A measuring tape so that staff get into the habit of measuring the patient's arm to ensure that they're using the right size cuff. And also laminated instructions for blood pressure cuff measurements. And also reflex hammer, of course, if it's elevated and you need to check reflexes, then it's already there. And if this can't be put into all patients' rooms, it might be something that can be available and accessible, but certainly something to consider to help with ensuring that blood pressure is taken accurately. Next slide, please. So it's really going to be a challenge to change practices, and you know, as it says here, create your burning platform. And what that actually means is that sometimes you have to consider where you are, and changing these practices is going to have a better outcome than not addressing them. So sometimes it's going to be hard to change what people are already doing, but if you're consistent and there's education and there's information and you hold staff accountable for the bad practices and ensure that you encourage them to continue using best practice, then you're going to have better outcomes. Make sure that equipment is inventoried at a regular interval, at least annually, and make sure that it's regularly inspected and that it's working accurately and calibrated, and that staff are aware of the standardization of blood pressure measurements, and ensure that protocols are updated to reflect these recommendations and guidelines. Next slide, please. Okay, that's all I have. Any questions, or certainly if there's anything that anybody has to add, I don't purport to be the expert in this, but I did want to share that. But if anybody has anything that perhaps I might have missed, please feel free to comment or to ask questions.
Okay, thank you, Lauren. Next slide, please. Okay, so this is just kind of to reminder, and we talked about one of the challenges in earlier webinars with being identifying cases and how to do that accurately. Just an overview. For case definition, 2 blood pressure recordings, 160 over 110, 15 minutes apart in the same position, seated or while in semi-Fowler's position with appropriate size and place cuff. Need to be able to identify patients with severe features of preeclampsia for magnesium sulfate administration. Both of those will be really important when it comes to measuring the P4 and P5, obviously, in time to treatment and for MAG administration. A couple of facilities have shared some of their, what they've tried to do and some of the challenges with how they're going to collect the data once patients are identified, building reports into their electronic system, and that can be include a whole set of challenges and expense oftentimes, or systems for being able to manually track patients with elevated blood pressures and how that's gonna go. I'll just open it for a second, and please use the chat box if you'd rather, and not speak up. If we would love to hear things that anybody has done or in the process of doing that looks like it might be a success, or you're going to have to, toss that and start again. Anything that anybody might could learn from will be very helpful. So.
Diane, this is Missy. I just want to make or add just a couple of things in response to a question that was in the chat box. So Trish asked about clarification. This is either the 160 or the 110. Could be both, but you only need to have one of those above that threshold for it to count. And then, Trish, you also, I think, had a question earlier in the chat about exclusion of folks who are known chronic hypertensives, and you are correct that when we're doing our P4 process measure, those folks are to be excluded. And how, as Diane is kind of saying, how each hospital, how easy it is for each hospital to exclude those who have chronic hypertension. I think that there are different ways that we can look into that, which may involve the medical record or may involve like the electronic medical record, or may involve old school ways of just being able to say that this is a person who has chronic hypertension, so they don't contribute to our numerator denominator for this particular process measure.
Thank you for those questions.
This is Tanya Mullen. I'm calling from Kennestone Labor and Delivery, and I just wanted to, I was going to type it, but I wouldn't be able to explain it well. I just want to tell you one thing that we have, I've been working with our EPIC people and our pharmacy person to try to find a way to track, because since we do about 500 deliveries a month, it's just too hard to look through medical records. And so what they've identified is using the blood pressure meds on our bundle and our order set to be able to run a report each month with the patients that have received those drugs in that bundle. And so what I'm working on now is, so that came from pharmacy. So pharmacy helped me to kind of extract that data, and then the people from Epic are now working to kind of customize a report for me to come each month, because it's kind of hard to, there's just no way to look through every record, so that's one thing. So, we're going to see if maybe we can find something on our hemorrhage bundle the same, that maybe we can pull something that would identify some of these patients as well. So that's just a thought. I don't know if it would work for everyone.
No,
thank you so much.
Thank you for that feedback. It's really important to be able to cross-reference not just those patients that receive meds, because we know those are the ones that are being treated, but also to identify those that have severe range blood pressures, and to see which ones have been treated and those that haven't, and to follow up why. It is a lengthy process, and that's one of the reasons why we are encouraging you to take some time to figure out what your process is, particularly for a unit like yours where you've got 500 deliveries a month. It can be quite lengthy and quite an intense process. So thank you for sharing.
Yes, thank you so much. I want the questions in the chat box are exactly what we were hoping would be added in terms of clarifying all the points to keep us all on the same page, but and to help get to some of the best practices that will end up coming out of this. So please, and not just on the call today, but as you encounter these questions or implementing processes, or you start something and you have to start again, please share those out just over email with us if you would, just ongoing. That's really helpful information. Next slide, Cyril. I'm sorry that this is not clear to see, and I had hoped to get it out to everyone before the call today, so you'd have something in more real time to look at. But I wanted to go ahead and share it up so that we want your feedback and we want your questions from this document before we do send out a final version. Okay, so this is kind of a more defined look at some of the slides we put up earlier with our process and structure measures. At the end of, beginning now for the first quarter, throughout the month of October, we're going to ask you to collect your measures for all of these, except for P4 and P5 this first quarter. So the number of drills and the drill topics, provider education, nursing education. We're not going to collect on treatment of severe hypertension, and I'm seeing some fields over in the green that I didn't fill in earlier. I apologize, but P5 will be treatment with magnesium sulfate, and P6 will be titled implicit bias education. So for this slide, it will be the unit drills, how many were completed and what was the topic. And for provider education, it's the number of physicians, midwives that have completed severe hypertension preeclampsia education in the last 2 years. And P2B is the number of providers, physicians and midwives, that have completed in the last 2 years an education program on severe hypertension and or preeclampsia bundle elements, and your unit standard protocol. For nursing education, the same thing as for the providers. And then for implicit bias training at the bottom, in this quarter, how many OB providers, nurses, and unit staff have completed within the last 2 years an education program on implicit bias. And we will make some resources known to you. We anticipate with in some of the upcoming webinars to provide some further guidance resources that are available and what other places and even other states have done to begin implementing implicit bias training. So look for more information on that. If there are facilities that have already moved more to have a process in place in your facility for implicit bias training and have some good experiences, good resources to share, we'd love to hear those. Okay. Are there any questions before I move on? Okay, and next slide. And the structure measures, as we kind of shared in the beginning, the OB-specific resources and protocols to support patient, family, and staff, and for debriefs, having a system in place. There was a question in the chat box about debriefs. Have we addressed that?
I don't think we have.
Okay.
But I think to some extent debriefs can happen based on what is the right fit for your hospital. I think most definitely somebody who has eclampsia, everybody should probably do a debrief on that. And then depending upon the frequency with which your hospital is managing severe preeclampsia or hypertensive emergencies, it may be appropriate to have more frequent debriefs, particularly at the beginning, to help understand your process and to help work towards improving it. But I think eclampsia for sure should be debriefed every time.
And so, Dr. Kotke, for a hospital that has, we have some hospitals in the state that have really, really high volumes, and I know that's one of the reasons this is a concern, obviously. But would they have maybe just in their hospital policy that they were going to do debriefs after those very, very severe cases like eclampsia?
Well, I think that we want to remind ourselves what the purpose of these are. And the purpose is to improve the process, right? To make sure that the quality of care that the team is able to deliver at every institution rises to the highest possible that they can at that institutional level. So part of what the hospital teams should feel that they have the flexibility of doing is to talk together about, what is going to be the value of the debriefs. We know that communicating across disciplines and with other team members is really, really important. And so having this here helps you kind of, use it, honestly, as an opportunity to say, nope, we've said that we were going to debrief on all of this because we know that our team can improve yet on this work. And so I would encourage them more frequently than not, particularly at the beginning, to help examine the process, examine communication, examine patient outcomes and satisfaction, and kind of all of those things. It can be a really nice thing to do. Would be, and like sometimes that just takes a little bit of time, depending upon how the hospital has previously approached debriefs. But I would encourage folks to consider them more frequently than less.
Thank you. Okay, and then having the structure in place for the multidisciplinary case reviews, unit policy and procedure, and electronic record integration. So again, these will, with the exception of P4 and P5, be reported for the first time by the end of October for the period of July 1st through September 30th. You'll get an email with the completed report form that'll follow up after this webinar, and please reach out to any of us during the month as you start to collect these with any questions. Okay, next slide, please. Okay, so this is these next couple of slides have I think we shared this out one time before, but we wanted to bring it back up because this is a data form that was developed first in California, adopted by then Illinois, and we've kind of stolen it from both of them, I guess. We wanted to be more deliberate about it now. I think we could envision a time when if these forms were used, or if this information were collected, that moving forward into the future, we could maybe have a system in place to actually have this data entered electronically. But for now, just to have this as a tool that's in place at the bedside to collect. You can see it goes through, patient information, obviously, but also some blood pressure recordings, medication administration, and the impact of the medications being given. A section on debrief. Terrell, would you go to the next slide? And then any complications, outcomes, you can record that. And also there's a place for race, ethnicity, if transport occurred, and kind of discharge management. Just in terms of doing this in your facility, the utility of it, would really love to have some feedback or some chat come across with your thoughts on it.
Maybe is this something that we want to share electronically, because there is a lot to digest on it.
Yes, certainly we can.
And then we can maybe talk about it again on the next call.
Okay. Okay, so look for that whenever we send the report form. We'll include this as well. Will you please go to the next slide? So the next month, we're going to have a section on educating patients and have Rebecca Britt from Preeclampsia Foundation who's going to present on that session. I think in the meantime, look for the email with the report information and with the bedside form. And please, that's all we have. But anybody have any last-minute questions or thoughts or anything we need to add?